Short range of motion isokinetic testing of wrist flexor and extensor strength in normal subjects and patients with carpal tunnel syndrome. Department of Physical Therapy, Faculty of Medicine, Tel Aviv, University, Tel Aviv, Israel, and the High Institute of Physical Education and Physiotherapy, Faculty of Medicine, University of Liège, Belgium. We're going to skip the abstract for now. Introduction. The two major clinical applications of isokinetic dynamometry are the quantitative determination of muscular performance status and monitoring its variation after trauma or intervention. Strength is most commonly defined in terms of the peak moment torque that derived from the muscle moment position curve that is obtained from testing along a substantial sector of the relevant joint's range of motion, ROM. The application of this full FRoM, FRoM, testing is by no means unique. Recent studies comprising trunk, knee, and shoulder muscles have indicated that the use of much shorter range of joint motion, SRoM, could yield similar findings while preserving subject safety and comfort. Specifically, in studies relating to knee flexion and extension strength from FRoM of 90% was split into three short subranges of motion, 0 to 30, 30 to 60, and 60 to 90s of flexion. The SRoM based strength scores, particularly those derived from the 30 to 60 middle sector, were strongly correlated, R is greater than 0.9, with their FRoM counterparts while evidencing clinically acceptable reproducibility under the both eccentric and concentric conditions. Hence, under their prescribed conditions, SRoM may effectively replace FRoM as a testing technique in normal subjects. However, the clinical use of SRoM testing for assessing weakness has so far been reported only in terms of comparison to normal reference values. In one such study, trunk extension strength in patients with chronic low back dysfunction was compared with that of healthy subjects. This patient group exhibited typical concentric and eccentric weakness patterns comparable to findings reported previously, but no within-patient SRoM or FRoM analysis was performed. Whether the SRoM approach is equally applicable in unilateral muscle weakness has not hitherto been examined. A recent preliminary study has indicated that the only valid indicator of unilateral muscular weakness was based on comparing the strength of the involved side muscles with their homologous counterparts in the uninvolved side. Moreover, it has been suggested that a 20% difference in strength between the involved and apparently sound side could serve as a benchmark for indicating a pathology or disturbed muscle function. A typical musculoskeletal pathology in which weakness sometimes is unilateral nature is a major symptom and thus can serve as a model for assessing the clinical utility of SRoM, testing its carpal tunnel syndrome, CTS. Patients afflicted with this syndrome often complain of weakness that is expressed as a difficulty in gripping and making fist, dropping of objects. In chronic cases, wasting of their thenar muscle may also occur. Although isometric tests relating to hand grip, pinch, and thenar muscle strength have been extensively reported, no corresponding isokinetic studies could be traced. However, based on previous research, we assume that isokinetic testing FRoM or SRoM based of wrist muscles in patients with unilateral CTS could be performed. Moreover, based on the symptoms, we hypothesized that the patient group would present with weakness of wrist muscles, that is, weakness as expressed by the strength of the involved versus uninvolved side muscles would be similar irrespective of the applied range of motion, short or full. Methods. Experimental approach to the problem. Using an isokinetic dynamometer equipped with a special attachment for measuring wrist muscle strength, the aim of the study was twofold: to test the feasibility of short ROM isokinetic testing in apparently healthy subjects and patients suffering from unilateral CTS, and to compare the extent of the weakness as derived from the two ROMs, the full and the short, subjects. A group of 15 apparently healthy women aged 27 to 38 years with a height and weight of 155 through 172 centimeters and 57 through 65 kgs respectively took part in the study. 7 women were right dominant. All subjects were pain-free during the test and took no analgesics for the last 6 months before the test. This group was designated the control group. Another group of 8 women, physician diagnosed with unilateral CTS clinical examination and electromyography study, affecting the dominant hand without any other musculoskeletal pathology of the upper extremity, formed the experimental group. Their age, height, and weight were 29 through 40 years, 158 through 168 centimeters, and 54 through 62 kilograms, respectively. All symptoms, pain and tingling, appeared at least 6 months before the study, but were not present at least 2 weeks before the test. As a result, no medications were taken by the patients during the time of testing. All patients declined surgery offered for relief of symptoms. This group was designated as the patient group. Tests were performed in the biomechanics laboratory, the Zimmerman College of Physical Therapy. All subjects signed a consent form. This study was approved by a local institutional review board. Instrumentation and procedure. Data were collected using Biodex Systems 3 isokinetic dynamometer, Biodex, Inc., Shirley, New York, USA. The test was conducted with the subjects in the standing position, forearm supported in the horizontal position, and the hand gripping the handle. The lever arm thus swiveled in the horizontal plane, and its axis was substantially aligned with the ulnar styloid process to allow free wrist flexion extension movement. The neutral position of the hand was defined as that in which the metacarpal bones extended straight forward from the forearm. From the position, the hand was brought passively to the position that corresponded to approximately 30 degrees of extension, namely forming an angle of about 150 between the forearm and the metacarpal bones. From this initial position, the hand was passively brought into 60 degrees of flexion, covering altogether an arc of 90 degrees. The FRoM, after RoM adjustment, a warm-up consisting of 5 submaximal concentric flexion extensions performed at 90 degrees per second were conducted, which was followed by actual testing. In the patient group, the test was performed bilaterally with the uninvolved side tested first. In the control group, tests were limited to the dominant side. Visual analog scale, VAS, pain scores of the patients were recorded before the test. Although some patients complained of pain, particularly during the eccentric exertions and at extreme hyperextension, none of the patients asked for the test to be terminated. For both groups within RoM, F or S, testing consisted of 2 parts, reciprocal concentric flexion and extension, followed after a 2-minute break by a reciprocal eccentric flexion and extension. In flexion, the hand moved from the initial 30 degrees of extension towards 60 of flexion, whereas the extension of the direction was reversed. The FRoM tests were conducted at 90 degrees a second, resulting in the so-called nominal movement time, NMT, of 1 second. Subjects were encouraged verbally to exert maximal effort. 5 repetitions were performed, and the average peak torque PT value of the best 3 repetitions was considered the outcome score. After a 2-minute pause, the eccentric test was conducted using the same order, but with reversed directions, namely 90 to 0 for flexion and 0 to 90 for extension. For SRoM, testing the 90-degree angular sector of the FRoM was decomposed into 3 SRoM as follows: SRoM1 from 60 to 30 of wrist flexion, SRoM2 from 30 to 0 of wrist flexion, and SRoM3, 0 of the wrist flexion to 30 of extension. The order of testing was random. That is, some subjects started with 0 to 30, 30 to 60, and 60 to 90, and others vice versa, 90 to 60, 60 to 30, and 30 to 0. There was an inter-SRoM pause of 1 minute. The same order of 5 reciprocal concentric tests, followed 2 minutes later by 5 reciprocal eccentric tests, was maintained. The SRoM tests were conducted at 30 degrees a second, resulting equally in an NMT of 1 second. Statistical analysis. Before data analysis, the PT values and ratios were examined for normality using the Kolmogorov-Smirnov Z test. All values were relatively normal distributed. K through S values 0.42 through 0.1, p-value of 0.22 through 0.99. For assessing the utility of SRoM in normal subjects, a repeated measure analysis of variance was used. Pairwise multiple comparisons were conducted to determine which means differed significantly using the Bonferroni procedure. In addition, to assess the relationship between the PT values within the muscle groups and between ranges, the Pearson's correlation coefficient, R sub p, was used for determination of the extent of weakness, if any. In CTS patients, paired t-tests for the following conditions were performed, involving 1. Versus uninvolved U, hand in each range, FRoM, SRoM in each condition, concentric and eccentric, extension and flexion. All analysis were performed using the SPSS 14.0 program for Windows. Results were considered statistically significant when the p-value was less than or equal to 0.05. Results. Normal subjects. Wrist extension and flexion PT values in both contraction modes are outlined in Table 1. As evident, SRoM1 derived PT's resemblance from their FRoM counterparts most closely. Based on both an absence of any significant difference between the two and an overall mean difference, concentric FLX plus eccentric FLX, concentric EXT, eccentric EXT divided by 4 of less than 2%, SRoM2 exhibited a low mean difference of 2.7% relative to FRoM, but together with SRoM3 yielded significant differences relative to FRoM in 2/3 of the combinations. The eccentric concentric EC strength ratios were greater than 1 in all conditions, Table 2. No significant differences were indicated between FRoM and SRoM1 in either flexion or extension. However, the ratio for SRoM3 was significantly smaller than either of the three range of motions, ROMs, whereas FRoM and SRoM1 were significantly different from SRoM2. Table 3 reveals significant correlation coefficients between FRoM and the SRoMs, 0.76 through 0.91 and 0.78 through 0.95, in extension and flexion respectively. These were higher than the within SRoM, e.g. SRoM1 through SRoM2 coefficients. Patients. In 7 patients, the level of pain as reflected by the VAS scores, not through no pain at all, 100 millimeters maximum sensation of pain, ranged 39 through 61 millimeters, indicating a general moderate level of pain. One patient rated her pain as 6.9 and complained of some discomfort after eccentric flexion. However, all patients complied well with the test and none reported any negative effect or feeling after completion of the test. Comparison of the strength of the apparently sound U hand and the corresponding values in normal subjects has yielded no significant difference. From Figure 1, we depict the PT values of the uninvolved U and involved I sides of the patient group. A uniform and significant weakness within movement and contraction modes is apparent. In view of this finding, the strength ratio, I over U times 100, was subtracted from 100 and averaged over the 4 individual weakness scores in each movement divided by contraction mode cell to yield the combined weakness score, CWS, outlined in Table 4. The mean CWS in flexion, concentric and eccentric, was significantly higher. P is less than 0.02 in flexion, 56.4 plus or minus 17.3% less in extension, 39.8 plus or minus 15.5%. Alternatively, the mean total weakness, flexion and extension combined, was 50 plus or minus 20.2 and 46.2 plus or minus 12.1% in the concentric and eccentric modes respectively. However, the difference between the modes was not significant, moreover, across all possible combinations. Absence of significant within-hand differences was noted only for the pair FRoM through SRoM1. Table 5 outlines the EC ratios in both the involved and uninvolved hands. All ratios were greater than 1, except in a single case. Notably, none of the combinations included a significant difference between FRoM and SRoM1. Table 6 indicates significant and clinically acceptable correlation coefficients between FRoM and the SRoMs in both the involved and uninvolved hand. For both hands, the coefficients for extension were greater than 0.9, except in a single case of 0.89. For flexion, the coefficients were generally slightly smaller, but still greater than 0.9 in more than 50% of the cases. Discussion. This main finding of this study is that the wrist flexors and extensor strength may be effectively measured in normal subjects and in patients with CTS using the short ROM approach, particularly when the angular sector designated the SRoM1 is applied. However, various aspects that emerge from the results deserve further elaboration. Muscular strength is not an absolute entity. First, it depends critically on the contraction mode, static or dynamic. Second, when its dynamic, isokinetic, variant is concerned, a large number of variables such as the type of contraction, range of motion, test velocity, test position, have an effect on the outcome. Indeed, as far as the range of motion is concerned, no standard procedure exists, and the diversity in this respect is quite large, particularly regarding joint systems like the trunk, shoulder, and ankle. In some respects, SRoM testing may be viewed as a hybrid between the static and dynamic testing, where one of the main objectives is to standardize the measurement protocol. Therefore, irrespective of whether any of the SRoM-based scores are in agreement with those derived from FRoM, the previous may be applied and duly interpreted, provided the results generally agree with those obtained in former well-conducted studies while conforming with physiological expectations. As for the first two studies have reported a range of 11.6 nm based on tests conducted, that's Newton meters, conducted at 30 through 180 degrees a second for concentric wrist flexion in women. The present strength scores derived from both FRoM and SRoM were largely within this range. For concentric extension in women, the PTs reported by the above studies ranged roughly 6 through 8 Newton meters, whereas in the present study the corresponding values were about 9 and 10 in FRoM and SRoM1 respectively. Table 1, eccentric PT scores were reported only in one study and related to women's performance at 60 degrees. Mean values were about 19 through 15 for wrist flexors and extensors respectively. In the present study, the mean PTs for eccentric flexion and extensor were between 11 and 13 Newton meters nm. Regarding the second element, because the tests were conducted using a single velocity for each test, ROM examination of one typical physiological parameter, torque-velocity relationship, is irrelevant. On the other hand, because all tests included an eccentric component of the EC ratios provided an important insight. The obtained scores, Table 2, in both groups revealed excellent agreement with known values in normal subjects, namely between 1 and 1.5 for the specific velocities that were used. Thus, based on the absolute Table 1 and relative Table 2 strength parameters, the findings relating to the normal group support the validity of the test procedure. Furthermore, the conspicuous similarity in findings between FRoM and SRoM1 and the high correlations between these testing variants, Table 3, strongly suggests that with respect to strength profile, SRoM1 and FRoM are interchangeable options for testing in wrist flexion and extension in both contraction modes in normal subjects. The reason for this observed close association between SRoM1 based strength scores and their FRoM counterparts is not a straightforward one. It may be related to the combination of factors encompassing the location of SRoM1 within the local wrist excursion, the intermuscular play in performing the various tests and test position. As for the location of SRoM1, various values have been mentioned for normal wrist ROM, 120 degrees from 60 degrees flexion to 60 degrees extension, 150 degrees from 80 degrees flexion to 70 degrees extension, and 160 degrees from 85 flexion to 75 extension. Hence, SRoM1 does not probably correspond to the most shortened position in the wrist flexors, and thus there is no risk of an active insufficiency of this group. On the other hand, it offers a favorable position for testing the extensors. However, what is not obvious is the possible role of grip muscles and its effect regarding the best compatibility with FRoM among the three SRoMs. When performing an isokinetic test of flexion and extension of the wrist, the fingers grip a handle that constitutes an integral part of the special wrist attachment provided by the manufacturer. Thus, instead of affecting a pure flexion extension pattern by placing the lever arm hand interface at the level of, for example, the metacarpal bones, the palm, this attachment mandates a firm grip of the handle, ostensibly to better stabilize the biomechanical axis alignment. This inevitably leads to load sharing by muscles not directly responsible for their measurement, namely the wrist flexors may be assisted by the flexor digitorum profundus, FDP, and superficialis, FDS, while the wrist extensors may equally be supported by the extensor digitorum communis, EDC. However, because of the eccentric function of the EDC during grip that is meant to block the active insufficiency of the FDP and FDS, the eccentric strength of the EDC is of particular significance during SRoM1. In fact, that is borne out conspicuously by the negligible eccentric strength difference relative to FRoM in this angular sector. Therefore, although from the length-tension relationship viewpoint, wrist flexors would have been put in a better position to act at SRoM3, the above combination of factors point out to SRoM1 as being the preferred short I lost my place. Being the preferred short ROM option. Regarding the function of the wrist muscles in patients with CTS, the similarity between the normal subject-based findings with those derived from the uninvolved hand is significant. It underlines the fact that although in most cases the uninvolved hand was also the non-dominant one, irrespective of whether it was weaker before the symptoms, its level of functioning was similar to the dominant hand of normal subjects. This may indicate some adaptive effect. When the strength scores were considered, Table 4, a significant reduction was unveiled in both directions and contraction modes. Of particular importance is the fact that the muscles of the affected side exhibited a fairly uniform decrease in strength vis-a-vis all SRoMs, as clearly evident from Table 4. In other words, the force output decreased similarly without specifically all affecting either of the subsectors. This is in agreement with the mechanical etiology of CTS, namely a neuropathy resulting from a general compression of the flexor tendon apparatus without implicating a specific component of the muscle. However, the observed weakness was significantly higher in the flexor apparatus, a finding that is in line with the clinical manifestation of CTS. Interestingly, the CWS was highest in eccentric flexion. Pain may be provoked more often with eccentric activities that are normally associated with higher muscular force output. In addition, eccentric contraction of the flexors is largely an unfamiliar activity in this muscle group and may be simulated by holding a balloon, which undergoes inflation. This should be compared with the eccentric action of the extensors that takes place whenever grip is affected to preserve the appropriate length-tension relationship of the flexors. Thus, although the eccentric extension is not a function that is concisely performed, it is not foreign to the neuromotor apparatus, which may account for the relatively least marked weakness among the four that were tested. To further probe the FRoM-SRoM duality of the EC ratios in both hands were computed, Table 5. Interestingly, all the mean values, save in the case of SRoM3 of the uninvolved hand and extension yield values that were greater than unity. Usually high scores were found for the involved hand in both FRoM and the SRoM1, 1.72 and 1.92 respectively. This might reflect specific controlled force output during concentric contractions because of pain. At SRoM1, the hand is most flexed, a position that is more likely to be associated with provocation of pain in view of the decreasing size of the canal during wrist flexion. 2. As expected from foregoing analysis, FRoM was also consistently correlated to each of the SRoM or short ROMs. Table 6. Irrespective of the hand, it is noteworthy that the highest correlations were obtained with respect to concentric and eccentric extension, but they were all within what is clinically acceptable, besides being highly significant. The principal limitation of the study is the use of a wrist testing attachment that involved hand grip as a component during performance of wrist flexion and extension. Because the moment output consists of all participating muscles, the net share of the wrist flexors and extensors could not be determined based on this particular experimental design. However, in view of the synergistic pattern between the respective hand plus wrist flexors and hand plus wrist extensors, it stands to reason that the final conclusion is valid irrespective. One solution in future studies would be to better isolate the individual effect of purely wrist muscles by having the volar and dorsal aspects of the palm push and resist against an accommodating force pad. Another limitation relates to the choice velocities of 30 and 90 degrees a second for SRoM and FRoM, respectively. The reason for this choice was the assumption that nominally the effective contraction times will be comparable. However, the current findings do not allow the determination of optimal velocities. Further research is indicated with respect to this question. Finally, a significant limitation was a small number of patients. In most patients, CTS occurs bilaterally, and therefore isolating unilateral cases proved to be difficult. Care was taken to exclude those cases that were borderline, resulting eventually in 8 patients only. On the other hand, the findings were, in our opinion, sufficiently clear to warrant reporting. To conclude, the findings of this study lend further support to the interchangeable use of full and short ROM isokinetic testing. Significantly, they indicate that this methodology is applicable also in the case of wrist flexors and extensors where the sector between 30 and 60 degrees of wrist flexion, SRoM1, is the recommendation SRoM. Furthermore, this testing mode is as effective in patients with CTS as is in normal subjects, and therefore paves the way for its possible incorporation in the clinical setting. Practical application. From the applied clinical point of view, this paper vindicates the use of isokinetic testing for assessing the severity of wrist musculature involved in patients with CTS. Normally, the functional status of hand muscles is evaluated using the standard instruments for grip and pinch strength. The findings derived from such tests may not reflect the full impact of CTS, as clearly shown in this preliminary analysis. Supplementing the latter with wrist muscle strength may provide clinicians with a broader and more meaningful picture and assist in designing a more efficient treatment plan.